Coming to the orbit, it is a pyramidal structure. The apex is posteriorly placed and it is at the level of the optic canal, and the base is formed by the orbital margin. Okay. So coming to the medial wall, lateral wall, and the roof and the floor. So the roof, as you can see here, it is formed by the frontal bone and the lateral wing of the sphenoid. Posteriorly in the roof, you have the optic canal. Okay. And then at the junction of the roof and the lateral wall, we have the superior orbital fissure. At the junction of lateral wall and the floor, we have the inferior orbital fissure. Okay, so coming to the medial wall, the trick to remember is USMLE. Okay, so take out the U. So first we have body of sphenoid, then MLE. So maxilla, lacrimal bone, and the ethmoid. Okay, maxilla, it extends onto the floor. Okay, and zygomatic, it forms the floor and also extends onto the lateral wall. So here we have the palatine orbital process of the palatine bone. Okay, and we have the orbital plate of the frontal bone here forming the roof, and finally greater wing of sphenoid which forms the lateral wall. Lesser wing forms the roof, greater wing forms the lateral wall. So this is how you remember the formation of this orbit. Okay. On the lateral wall, we have an important feature called the Wittnall's tubercle. On the roof, the relations include, we have anterolaterally, we have the lacrimal gland, and medial to it, we have the trochlear notch, okay, through which the superior oblique it anchors to the pulley. Now, coming to the contents of the orbit, we have the eyeball. It occupies the anterior 1/3 of the orbit. We have the periorbital fascia and the bulbar fascia. Okay, next we have the extraocular and intraocular muscles of the eye. We have ophthalmic artery, superior and inferior ophthalmic veins and lymphatics. We have optic nerve and 3-4-6 nerves, cranial nerves, and we have the lacrimal gland and also orbital fat. Okay, now coming to the orbital fascia. So it is also called periorbital fascia. It forms the periosteum of the bony orbit, and because it is loosely connected to the bone, it can be easily stripped. Okay, so it has both an inner aspect and an outer aspect. So coming to the inner aspect, it continues along the margins of the superior orbital fascia, orbital fissure with the endocranium of the skull. Coming to the outer aspect, it continues with the periosteum of the bone. Endocranium inside, periosteum outside through the intraorbital fissure. Okay, so that is about the periorbital fascia. There is a gap in the periorbital fascia over the inferior orbital fissure, as you can see here. Okay, it is bridged by connective tissue which involves a few smooth muscle fibers, and this constitutes the orbitalis muscle whose function is unknown. Okay, so coming to the modifications of this periorbital fascia. So what happens is, it sends up at the upper and lower margins of the orbit, it sends a flap-like continuations into the eyelids. These form the orbital septum, as you can see here, at the upper and lower margins. Okay, so actually, coming to the extent, posteriorly it is continuous with the dura mater and the sheath of the optic nerve. Anteriorly it is continuous with periosteum, as we discussed. Okay, so it sends orbital septum, and then it holds the fibrous pulley for the tendon of superior oblique, and it also forms the lacrimal fascia which bridges the lacrimal groove. Okay, so you can see all this here. It forms the lacrimal fascia which bridges the groove. Okay, posteriorly it is continuous with the sheath of the optic nerve, anteriorly periosteum. Okay, and it also forms the lacrimal groove, and also the septum. Okay, so all that is formed orbitalis muscle also. Coming to the Tenon's capsule or the bulbar fascia. Okay, so it is a membranous coat that covers the recti and the oblique muscles. So medially it encloses medial rectus and attaches to the posterior lacrimal crest. Okay, and it forms medial check ligament medially. Laterally it encloses the lateral rectus muscle, attaches to Wittnall's tubercle, and forms the lateral check ligament. Inferiorly, okay, it merges with inferior oblique and inferior rectus, as you can see here. Okay, and it forms the suspensory ligament of Lockwood. Okay, and this ligament helps in preventing the sinking of the eyeball downwards. So coming to structures attaching to the Wittnall's tubercle, we have 4 structures. All of them start with L. Wittnall, all are L. So lateral palpebral ligament, lateral check ligament, levator palpebrae superioris, and Lockwood suspensory ligament. Now coming to the extraocular muscles of the eye. Okay, other structures formed by the Tenon's capsule include the lateral and medial check ligaments, the suspensory ligament of Lockwood, and also it forms a loose thin membranous sheath around the eyeball. This sheath is pierced by tendons of extraocular muscles and also ciliary vessels and nerves. Coming to extraocular muscles, we have involuntary and voluntary muscles. Coming to involuntary muscles, we have the superior tarsal muscle, which is the derivative of the intermediate layer of the levator palpebrae superioris. Then we have the superior tarsal muscle. It is inserted onto the upper margin of the superior tarsus, elevates the upper eyelid. Inferior tarsus muscle, it extends from the facial sheath of the inferior rectus and oblique to the lower margin of inferior tarsus, depresses the lower eyelid. Orbitalis function is unknown and it breaches the inferior orbital fissure. Coming to extraocular muscles, we have the recti and we have the obliques. Okay, so coming to the recti, you have to understand one thing, that the superior rectus, the angle is at 25 degrees, as you can see, and the inferior and the superior oblique and the inferior oblique, it goes, inserts, obliques insert behind the equator, recti insert in front of the equator. Okay, so the axis is 51 degrees, 25 degrees, 51 degrees. Okay. Now coming to the voluntary extraocular muscles, we have the recti, the obliques, and also the levator palpebrae superioris. Coming to the levator palpebrae superioris, so it takes origin from the lesser wing of the sphenoid, and insertion, it divides into 3 laminae, diverging laminae. The upper lamina, it consists of skeletal fibers and inserts onto the upper eyelid, so that is what actually elevates your upper eyelid. And the middle lamina, superior tarsal muscle, it's derived from it, and it is composed of smooth muscles. Inferior lamina, it attaches to the superior fornix of the conjunctiva. Okay, inferior lamina attaches to the conjunctiva. It is also composed of smooth muscles. Okay, that is the levator palpebrae superioris. And coming to the recti, all of them take origin from the common tendinous ring. Alright, so they insert onto the respective sides of the eyeball, in front of the equator and behind the corneoscleral junction. Okay, so common tendinous ring or annular ring of Zinn. Okay, so that is it. Mention the axis also. And then the various insertions, they include 5, 6, 7, 8. That is mils. Okay, mils, milli Bobby Brown mils, 5, 6, 7, 8 behind millimeters behind the sclerocorneal junction. Okay, coming to the superior oblique, it takes origin from body of the sphenoid close to the apex of the orbit, passes through the trochlear notch in the roof of the orbit, hooks to the pulley there, and inserts in the posterior superior quadrant of the eyeball. Okay, inferior oblique also, posterior superior quadrant of the eyeball. Okay, inferior oblique takes origin from the floor of the orbit. It is the only muscle taking origin from the floor of the orbit. Okay, then mention the axis also. Nerve supply, all solar 346. Okay. SO4, LR6, you know this. Coming to the axis, abduction and adduction take place around a vertical axis, okay, like this. And elevation and depression, they take place around the transverse axis, like this. And intorsion and extorsion, they take place around an anterior-posterior axis, like this. Okay, coming to the actions, medial rectus, the recti, medial rectus adduction, lateral rectus abduction, that's it. Okay, next, superior rectus elevation, and also inferior rectus depression, we know this. Along with that, superior rectus performs adduction, inferior rectus also performs adduction. The recti, they adduct, the oblique muscles, they abduct. Okay, and also what all muscles are superiorly located, they perform intorsion, sin, and obliques, they abduct. Okay, remember it like this. So coming to the structures that pass through the superior orbital fissure, so we have supralateral compartment, common tendinous, and inframedial compartment. In the supralateral compartment, LFT, lacrimal nerve, frontal nerve, and trochlear nerve, and along with that we have the superior ophthalmic vein. Inframedial compartment, we have inferior ophthalmic vein, and also in the supralateral compartment we have the recurrent meningeal branch of the ophthalmic artery. It is a branch of the ophthalmic artery. We'll discuss that. Within the common tendinous ring, the structures that pass include LFT for Sonia Gandhi. Okay, so what is O? O for oculomotor. So superior and inferior divisions of the oculomotor nerve. Okay, and we also have the abducent nerve and also small nasociliary nerve. You can remember it like this. See, LFT. Okay, so third nerve. The fourth nerve, it is before the common tendinous ring. So the third and sixth nerves, which are supplying the muscles of eyeball, they have to pass through this ring to supply the muscles. Okay, now also coming to the optic nerve and all that, within the superior orbital fissure in the common tendinous ring, these structures are passing. Okay, so that is the oculomotor superior and inferior, abducent, and along with that we have this nasociliary nerve. So outside that, within the common tendinous ring, the optic canal is there. In the optic canal, the structures passing through it are optic nerve along with its meningeal coverings, and along with that the ophthalmic artery. Okay, structures passing through inferior orbital fissure, we have the maxillary nerve, we have the zygomatic nerve, and also inferior orbital vessels and nerves. Okay, so that is about the structures passing through it. All right, and now coming to the arterial vessels of the orbit. So the ophthalmic artery, it is a branch of the cerebral part of the internal carotid artery. Okay, so coming to its course, so the artery enters the orbit through the optic canal. First, it is inferolateral to the optic nerve. Okay, both artery and the nerve lie in a common dural sheath. Then it is inferolateral first, then it pierces the dura mater in the orbit, becomes lateral to the optic nerve, and crosses the nerve from lateral to medial side. It then runs forwards along the medial wall of the orbit between the superior oblique and the medial rectus muscles. Okay, and it terminates near the medial angle of the eye by dividing into terminal branches, that is supratrochlear and dorsal nasal branches and supraorbital branches. So, okay, so coming to the branches, while still within the dural sheath, it gives the central artery to the retina. Okay, it gives the central artery to the retina. After piercing the dura mater, it gives off a large lacrimal branch that runs along the lateral wall of the orbit. So, the ophthalmic artery is first inferolateral, then lateral, and it passes from lateral to medial to go on to the medial wall. Okay, so it gives a large lacrimal artery which goes along the lateral wall. Okay, it goes through the lateral aspect. So what are the branches from the lateral artery? It gives branches to the lacrimal gland and two zygomatic branches, because it is going like this through the zygomatic arch, like that, in relation to that. So it gives two zygomatic branches. Okay, zygomaticofacial and zygomaticotemporal, and then laterally it is going, so it supplies the lateral palpebral branches. It gives off those branches that supply the eyelids from the lateral aspect, and also gives a recurrent meningeal branch. We discussed that it passes through the supralateral compartment of the superior orbital fissure, and it anastomoses with the meningeal branch. Okay, and then also we have muscular branches that supply the muscles of the orbit. Okay, these are and then coming to central artery of retina, it is the first and most important branch of the ophthalmic artery, lies below the optic nerve and pierces the dural sheath and runs forward for a short distance, and then enters the substance of the nerve and then runs in forwards in the center to reach the optic disc. Okay, here it divides into branches that supply the retina. Central artery of the retina is an end artery. Okay, it does not have any effective anastomosis with the other arteries, and occlusion of the arteries results in blindness. Coming to branches from the main trunk. Okay, the long and short, the posterior long and short ciliary arteries. Okay, it gives long and short ciliary arteries like this. They run to the long arteries run to the ciliary body, and short ones, they just supply, the choroid and all that. Okay, the choroid and the iris. Okay, so, and we also have the supratrochlear and supraorbital arteries. Okay, they're given like this: supraorbital and supratrochlear arteries from the main trunk, which is medial. And then we have anterior and posterior ethmoidal branches that supply the anterior and posterior ethmoidal air sinuses. They again anastomose after passing through the respective foramina. And then medial palpebral branches, and also dorsal nasal branch that supplies the upper part of the nose. Okay, coming to ophthalmic veins, we have superior ophthalmic vein which accompanies the ophthalmic artery. It lies above the optic nerve. Okay, it receives tributaries corresponding to branches of superior ophthalmic artery, and then it passes through the superior orbital fissure, supralateral compartment, drains into the cavernous sinus. Okay, it communicates with the angular veins and supraorbital veins. Coming to inferior ophthalmic veins, runs below the optic nerve, receives tributaries from the lacrimal sac, lower orbital muscles, eyelids, etc. And it ends by joining either superior ophthalmic vein or directly into the cavernous sinus. It communicates with the pterygoid plexus of veins by small veins passing through the inferior orbital fissure. Coming to movements of the eyeball, despite what we have already discussed, conjugate movements occur when the axes are parallel and eyes move in same direction. Disjugate movements occur when the axes of both eyes converge or diverge. Okay. And now coming to factors maintaining the stability of the eyeball, we have anteroposterior stability, which is maintained by the recti and the check ligaments and also the orbital fat. Vertical stability is maintained by the suspensory ligament of the eyeball or suspensory ligament of Lockwood. Okay, it prevents the sinking of the eyeball. Now coming to the applied anatomy, unilateral paralysis of the individual muscles due to involvement of nerves produces strabismus or squint and may result in diplopia or double vision because light will not be focused onto the central part, okay, of the retina, okay, will not be focused on identical areas of both retinae. Okay, now paralysis of lateral rectus produces muscle to turn internally, right? So it produces internal strabismus. Paralysis of medial rectus is expressed as external strabismus. Superior rectus produce diplopia on looking up, and also inferior oblique produces diplopia on looking up. Okay, whereas inferior rectus and superior oblique, they produce diplopia on looking down.